to a lot of things that I've always cared about. An opportunity to come and talk to you and hear from you. And if you don't mind, I'd like to, at first I was thinking, okay, how do I approach this opportunity? Do I, bang out 4,000 or 5,000 words, which is I'm not that strong of a writer, and give a speech, or do I, try and pretend I'm a researcher or an academic to impress the folks in the room? And then I thought, and even today, as I've had a chance to talk to a few folks and to reconnect with Amy, I think what's going to work best is for me to, and give you a sense of what it is I do and how I do it and why I think it's important. Working in politics, and given the political climate that we're in, that there's people have an urgency to talk about things other than all the nonsense that's going on in Washington and that I unfortunately have to put up with, but that we shouldn't all have to put up with, because we have an opportunity to continue doing the things that we do and to do them well and to move things downfield, regardless of who's in the White House, regardless of who's running Congress. I mean, we have to engage that process, but it doesn't have to keep us at arm's length. There's still too much to do, and it's too important. And maybe we could. Can you hear me in the back? Yes. Okay. Good. So I'll start just by giving you a sense of where I fit in the nonprofit world and the work that I do, why it's important, a little bit of my personal story, which very much informs what I've done in my career, and I'd like to then talk about why it's important for all of us, regardless of where we sit and the work that we do, because we're concerned with the social good. Fundamentally, we have an obligation, a duty, as stewards of those intentions, to make sure that young folks who are coming up, and children in particular, that their needs are met and that they're nurtured in the appropriate way, so they can continue to do that good work. And so that the stewardship of that advocacy work is very important to me as I round into as I tell my wife and kids, into my final laps around the track. None of them believe it, but I tell them, it's important to me. Legacy of the work that we're doing is important. So with that, Children's Health Fund. Children's Health Fund is a 501c3 national nonprofit. It was co-founded by my then boss, who was a pediatrician named Erwin Redlener. And you may see his name pop up, even though he's an emeritus. He's got an article in this morning's Washington Post about kids at the border who have, unfortunately, we've had another death at the border. And he is, even at this date, after a generation of informing public policy, continues to do the work. In any event, and Paul Simon, who was amazing and continues to be amazing, but this program got started in the 80s, in 1987, when New York was at the height of its the consciousness of its homeless crisis. I mean, there were, this confluence of events that brought homelessness into the public sphere in a way that it hadn't been before. And Paul and Erwin, my boss, had gotten together. He was the chair of ambulatory pediatrics at Cornell Hospital in New York. And they were responding to an urgent call from one of the larger welfare hotels. And for those of you who don't remember what those are, they are these single room occupancy hotels, many of which were in Midtown Manhattan, where you'd have 1,000 rooms in a dilapidated structure, and homeless families, and many of them children, were living in these hotels, because New York is unique in that it has a right to shelter. In New York, if you are homeless for any reason, the city is required to provide emergency housing for you. So there was as the city's become a more expensive place to live, people have gotten squeezed out of the traditional places to live. Would end up being homeless for a variety of reasons, and then they'd get into the system and end up in one of these large welfare hotels, as they were called. those places were Dickensian. I mean, you were, people not well supervised, kids without appropriate supervision, kids with health needs that were being met primarily in emergency rooms. And the people who were running these shelters, they said, well, look, we'd like to reach out to some nonprofits, see if they can help us. And they invited Erwin and Paul down, and they asked, they said, look, these kids need health care. A lot of them have chronic conditions like asthma. They're going to the ER. If we could just round up a few doctors and put them on a bus and bring them down here, see some of these kids, that would really help. So Erwin and Paul put their heads together. They raised some money. They invited some of their showbiz friends and did a concert in Madison Square Garden, raised a bunch of money, and they designed a mobile medical unit to go to the homeless shelters. But my boss, because he is a pediatrician and he has a deep understanding of what equity is about, he wanted a model of healthcare to be made available to kids that was the equivalent of the model of healthcare you would expect as a middle-class parent in Park Slope, which I am, and would expect for my kids, And so they designed this unique state-of-the-art mobile medical clinic with the staff, paid staff, to be a doctor's office on wheels, but it was very much based on the concept of the medical home, okay? It wasn't episodic. It was what you would anticipate for your own children. A place where the healthcare was continuous, comprehensive, accessible, coordinated, where the records were kept, where they could be accessed. And our first mobile unit started going around to the homeless shelters, fully staffed, on a regular schedule, and became the healthcare provider to that population. Meaning that if a child got sick in the middle of the night, or had a condition that required they be seen, they could pick up the phone 24/7 and call and get their doctor, not some nameless, faceless health service, but their doctor. And they built that, the whole program was built on that model. So we got a lot of interest. I hadn't joined the organization yet. Amy mentioned I've been there for 27 years. This was about 32 years ago, but there was a lot of interest and requests from folks around the country for a similar model. And so what we got was this, a network of programs. We support about 55 mobile programs on the road now, providing comprehensive primary care, mental health care, dental care, to very medically underserved pediatric populations. In New York, it was homeless kids. But in West Virginia, it's poor white children who live in the hollers of Huntington. In Bisbee, Arizona, and Cochise County on the border, it's very medically underserved immigrant children, regardless of their status. And so we now have a network of 26 programs, and we just launched a program in Puerto Rico, which I'll talk a little bit about later in the context of our work doing disaster relief. They're all based at major medical institutions. We don't fully support them. We are partners with some of the best institutions around the country. You can see on our map, Tulane, Phoenix Children's Hospital, La Bonner in Tennessee, Montefiore, which is our biggest program by far in the South Bronx in New York, where we now have 5 mobile units that provide health care and are the biggest provider of health care to homeless kids in the country that are serving the kids in the New York shelter system. And I might add that in the mid-'80s, when we thought, this is a wave of homelessness, but the United States, we're a great country, we're a wealthy country, we're gonna get a handle on this problem. Well, there are more homeless kids than ever, right, in the shelter system. And back during the war on poverty, and I'll get to that a little bit later, we thought, there's poverty in this country. How is it possible that we could have this level of poverty in a country as rich as the United States? And surely, in the 50 years since then, we would have tamed that beast. But of course, we haven't done that either. So, these are long-standing issues that have informed me, that have informed my growth in my career as I seek to get to the heart of some of those matters in the places that basically determine where the resources are allocated and how much, and that kind of thing. So that's led me to advocacy. So That's what's unique about the Children's Health Fund and our network. We are mission driven, and we support 26 clinical programs, about 55 mobiles on the road around the country. But we're a hybrid organization in that we take what we learn in those clinical programs and we use it to drive policy and advocacy based on what we learn. It's kind of a canary in a coal mine type of model where, what happens out there that affects children and access to care, we hear about it, and we try and be very nimble in our advocacy to try and focus on the things that matter to kids. So, the enhanced medical model is meant to highlight the growth. We thought originally it was just a matter of getting kids to primary care, but with more understanding of what kids need, we've found that the need is great in some specific areas, mental health, oral health, keeping up with technology relative to electronic health records and telemedicine. And then there are other things that would fall under the banner of what's called the social determinants of health. And we'll talk about that in a minute, but transportation is a huge health barrier in many communities. And of course, with the focus on health equity, and you're hearing more and more about this, obviously, politically now it's a highly charged issue. You hear Medicare for all, you hear single payer, you hear ACA, you hear pushback, and on all of those. But it's, we have a large focus on health equity. And what does it mean from our perspective? It means that every child should have access to a medical home, the full range of services that children need to grow and thrive. That children are healthy enough to learn, and we have an initiative called Healthy and Ready to Learn, which focuses on that, and that that health should never be an impediment to children and opportunity, because we're all invested in children having as much opportunity as possible and being able to fulfill their potential. So, I just mentioned, I touched on a few of these, and just to give you an idea of the scope of the things we've been involved in over the years, it started with homelessness, and then it became a matter of whether there were going to be enough federal programs, and this what we refer to as the Child Health Safety Net, Medicaid, and other programs, and whether they would remain funded to the extent that they needed to be as effective as they needed to be. There are issues. We weighted in the difference between insurance and access as more kids became insured. We found that having an insurance card didn't really guarantee that kids would have access to care. There are huge issues with access. Kids First, Kids Now was our bid during the '94 Congress, which some of you may be old enough to remember was the contract with America, and it was when the Republican right really took hold of the House of Representatives under Newt Gingrich. That's when we ramped our advocacy up in Washington and started really getting embroiled in the controversies about health and access down there, rather than just talking about it from New York. We did a few child health caravans. We took our mobile units and had staged high-profile events going through the different parts of the country, and on and on. So there have been, the advocacy landscape is very robust. There are a lot of different fronts to prosecute a case on behalf of kids and what they need. And fortunately, there are a lot of, look, I'm a registered lobbyist. I have to be, even as a children's advocate, in order to participate in the scrum that it often turns into. But as an organization, we have some amazing tools and assets that help us. And we're not a large organization, and I'd like to say that we punch way above our weight, but we have exceptional pediatric leaders, some of the finest individuals you'd ever want to meet, who run our programs in different parts of the country, and they bring a passion that is unbelievable on behalf of kids. And for any of you who know pediatricians, you know that they're a doctor apart, in my view. They really do bring a sense, for the most part, of a social mission to their work in helping kids to grow and thrive. So we've got a very high-performing clinical network, which gives us some chops in terms of research and the ability to provide evidence for what we are advocating for. We've got some committed funding partners, including we've had a history of support from a variety of different places: foundations, corporations, individuals. Paul Simon has been a champion for us. Okay, and so one of the reasons we're effective is because we have a bipartisan orientation. You know, I got hired because coming out of my graduate work, I made a point of wanting to work in a bipartisan way because, you know, as you can see, you pick up the newspaper, we're a country that's very polarized. In order to get anything done, we have to find ways to move away from that and to do things in a bipartisan fashion. And though it doesn't always give you the visibility and excitement that you want at any given point in time, over the course of my career, I've learned, like the turtle and the hare, that if you keep slow and steady in a bipartisan way, you're likely to be able to have a higher chance of success. And just today, there was a health bill that got passed on the Senate side to deal with medical emergencies and some aspect of Obamacare. And the reason it was so unusual is because it was co-sponsored by two very conscientious senators, one from each party. So that's necessary. As a small organization, we're tactically flexible. We have a good sense of how to leverage media and communications tools to get our message out. And we've managed over the years to establish a pretty firm presence in DC as well as other places, which really helps because so much of what happens down there is insular, and you have to be part of that conversation in order to be influential. So, why is advocacy on behalf of children a long-standing and urgent necessity? I mean, you know, there's thinking in this country, especially, that the children's advocacy should begin and end with parents. You know, for the most part, they're the primary, and they are the primary advocates for children. But there's a limit, and there are a lot of things that have to happen at a more macro level in order to make sure that the resources and policies are in place to do things, especially for kids who are poor, underserved, and marginalized. So, just to give you a sense, the share of federal spending on children in FY 2018, you can see that's the sliver, 8.06%. That's the amount of federal spending on children's programs in the budget. Okay, 8%, and not going any higher than that. It seems it's been hovering around. It was in decline for a while. It seems to have stabilized a little bit, but 8%, 8 cents on the dollar. Okay, and the long-term trend for children is a disaster. And the Urban Institute projects that in the next, well, now 8 years, as a share of all projected growth in federal spending, the adult portion, Medicare, Social Security, Medicaid, 61%, interest on the debt, 29%, children, 1% of the increase. So children's projected 1 cent on every dollar of the projected growth in spending over the next decade. And the budget process, so, there's a budget process in this country that, the House proposes a budget, the President proposes a budget, they work on it, and then there's funding that's entitlement funding, and there's funding that's discretionary funding. The entitlement funding is the funding that, Medicare, Medicaid, those are programs that automatically, people are entitled to. The government says, we're going to give you money for these purposes. Disproportionately spending on children is in the discretionary pot, which means we've got to go to Washington and fight for it every year, advocates. And there's a myriad of programs, everything from CDC and maternal and child health. They're just literally hundreds of programs in education and health and juvenile justice, that they get out through what I consider a fairly arcane process of appropriations bills. 14 of them every year have to be negotiated. Sometimes it doesn't happen. In the last few years they've had budgets delayed and continuing resolutions, all this stuff. But essentially, kids programs fall into that pot, so we have to fight for them every year. So taken together, these features of the current budget process are increasingly leading spending on children to be crowded out as the burden we place on children rises. So, that's an unsustainable course forward. And as things rise and fall economically in this country, traditionally there was a point in the early 70s after Medicare came on board in the mid 60s, and Medicaid and Social Security. Well, the Social Security was around for a long time, but the bottom line was the number of seniors in poverty dropped dramatically, as you can see, and continue to go down. I mean, but kids stubbornly, the poverty levels of children have remained high. So there's an imbalance there that is very, very concerning, and it's longitudinal. All right, I'll skip that. So that's the federal landscape, and that eats up a lot of my airtime because that process rolls on every year, and there are advocacy groups and service providers, et cetera, that count on dollars, federal dollars coming in, and the federal government making a commitment, and so that eats up a lot of it. But there also is a child health provider organization. We're concerned with a schedule of what we refer to as health access barriers, and these are the things that institutionally cause us to have reduced child health access, and so we have to maintain a vigilant approach to these things to try and roll them back to improve child health access, and that starts with health professional shortages, which there are thousands of communities that are designated as HPSAs, health professional shortage areas, and those are places mostly rural, but some urban, where there just aren't enough providers to serve the population. It's a hard ratio of 1 to 3,500, and so there are thousands of communities that meet that criteria. Transportation, which I'll touch on in a minute, we have a transportation initiative, is a real problem, again, particularly in rural communities, but there, nearly 40% of the country does not have public transportation. So, that becomes a problem. Of course, if you have an emergency, you need to, they'll air vac you. You can always get to an ER, but we're talking about routine health care. So if a kid who has asthma and they need to have their chronic asthma managed, they have a problem if they don't have transportation. Immigration status is increasingly an issue, and it's going to be in the news even more over something called public charge, where now there's going to be a regulation change in Washington to where use of programs like Medicaid in families is going to be charged against the citizenship application of the family where that's using the service. So this is having, as you would imagine, a dampening effect. There are a lot of the families where there are immigrant families. The children are mixed status. Some are here. If they're born here, they're legal citizens. Others may have come here and they're not. If families feel like it's going to count against their ability to become citizens, they're going to decline to use the service, and everyone gets hurt. So that's a problem. Disaster response and recovery. We with Katrina and various other major storms, there's always always has a devastating impact that's much more pronounced on poor and underserved populations, and so that's that becomes an access barrier. Kids try and deal with the aftermath of those things, and then finally the big issue, the big kahuna, is poverty, and we have a very stubborn problem with child poverty in this country. I'll get to that a little bit later, but that is definitely an access barrier. Again, as we look at social determinants of health, poverty is really the largest determinant. Okay, I'm going to run through these quickly. Yeah, okay. So lack of transportation, I talked about that. We have a program that, an initiative that, and an index that we've developed to help identify transportation disadvantaged areas at the Health Fund, and we've had to fight to maintain the regulatory side of funding to support non-emergency medical transportation. Health barriers to learning, another major initiative that we've been involved in, where we help schools to identify what's called health barriers to learning and to address them quickly, so kids miss a minimum of school maximize their chance of being educationally successful. Amy mentioned that I also work at the National Center for Disaster Preparedness. We have an initiative called Resilient Children, Resilient Communities. It's the need to really involve communities and to work closely with them, not only to prepare for disasters, but to be able to respond effectively, to get services and schools up and going as soon as possible so kids don't lose ground, because often when poor and underserved kids lose ground, they lose out. And then, I'd just like to touch on this, the social determinants of health. I'm not sure, how many folks have heard that term, social determinants of health? Okay, so, in an audience that is academically aware, in the literature, it's their social determinants are complex circumstances in which individuals are born into and live and that impact their health. A lot of it has to do with the things EDRA cares about, designing communities that work. Oftentimes, the problem is, the services aren't there, they aren't built in, they aren't planned, and people aren't thoughtful about them unless they are meant to appeal to certain populations. If they're underserved populations, they often get marginalized. So the social determinants of health start with the social factors like, racism and inequality and poverty. And there you can look at this graphic, you can see in living and working conditions and public services and infrastructure, is there enough thinking going into how we're designing and redesigning communities as they change, and are we mindful enough of the social determinants of health and how the health of residents can be impacted if those things aren't taken into account. In terms of poverty, which as I mentioned is the biggest of the big deals, there's a movement, the National Academies just issued a report, a roadmap to reducing child poverty, and the takeaways from that report are fairly compelling. We can cut child poverty in half, as they've done in the UK, within a decade if there's the political will to act. And reducing child poverty is extremely cost effective. We can do it for depending on how we want to do it in a very direct, targeted way. And in doing so, in reducing child poverty, improving children's health, nutrition, and educational outcomes. Okay, so on to stewardship. And this is where it becomes a personal thing for me, because I grew up not far from here in Williamsburg in a housing project. And not just any housing project, it was one of the original, the second or third housing project put up in the country. It's federally funded, built in 1936 in the aftermath of the Depression. And it was meant to, on a very human scale, in a very humane way, provide a better life for people who were, coming up and coming out of, the working class, and very much meant to give them a reasonable approximation of what middle class living was like in this city. And my memories of that are extremely, extremely positive and fond, as I was able to have access to the institutions, community-based, that helped communities like mine thrive. My parents moved in 1949. They were the third black family in, and my mother spent her entire life there. It was amazing. So I know what can be accomplished. Now, they went through very rough times, and I ended up leaving when I was a teenager to go to college, and I never moved back, but I watched that community deteriorate. And I watched, though, the emphasis on building, addressing the need of those populations change. Now, it seemed like they were building high rises, and it was the folks that I knew in those situations just had a very different outlook on what they were in the middle of. And I knew the times were changing, but to me, it was the 60s, and when EDRA was born, and I had a political awakening, and it occurred to me that maybe I really wanted to be involved in helping to make sure that the commitment was still there for communities I cared about. So this is what put me on my path to doing advocacy work. Now, stewardship is one of the most important concepts we can define. According to Merriam-Webster, It's the conducting, supervising, or managing of something, especially the careful and responsible management of something entrusted to one's care. And to me, the idea that we should have equity and that government should work to support people and communities should help children to thrive is, is one of our highest ideals, at least mine. And so, I'm anxious to be working on things that help get me there. But it's not without a sense of some of the folks who came before me and inspired me. And I just wanted to show a couple of quick videos about two heroes, personal heroes. One is Dr. Jack Geiger. And Dr. Jack Geiger is a physician who's headed a bunch of organizations that were visionary for their times, the Physicians for Social Responsibility, Physicians for Human Rights. He's still alive, he's 93 years old, but he's the father of the community health center movement. And the community health centers, if you don't know, is the network of health providers for poor and underserved and populations, rural populations, and they do incredible work. About half dozen of our programs are based at FQ, what they're called federally qualified health centers. And I'm going to see if I can't actually switch this on, if I can do that. I thought it would come on by itself. And here we go. Oh, this is the wrong one. Damn it. Okay. This is the video of Aaron Shirley, another hero. You'll hear about him. He's an African-American pediatrician.
It's a modern-day medical miracle. It is a unique miracle in that this is one of a kind, hopefully just the first of its kind, because many other cities across the nation are looking at it with the idea of imitating it. But this is the first, and it is phenomenally successful. The story of Jackson Medical Mall is best told from the present looking back, because it's rather unbelievable from the front end looking forward toward today. But right now, the mall is 100% occupied, and the retail strip mall across Woodrow Wilson from it is 100% occupied. Other retail and service establishments dot the landscape around the medical mall, and plans are being put into action to revitalize the residential areas adjacent to it. And properties being acquired for what will become a medical corridor from I-55 with access to Lakeland Drive and the Jackson International Airport, with the University Medical Center on the east, the medical mall in the middle, all the way to Hawkins Field Airport on the west. This medical corridor will incorporate research facilities, treatment centers, and clinics, as well as communities within walking and bike riding distance to the facilities for the people who will be coming here to work in them. Now, how did this start? Well, it started with an offhand comment made by Dr. Aaron Shirley as he was eating lunch with Judge Reuben Anderson at Piccadilly Cafeteria, one of the few businesses still surviving in the old Jackson Mall back in 1995. At the time, Dr. Shirley's Jackson Hines Comprehensive Health Center was pinched for space, and looking around at the empty old retail mall, Dr. Shirley made a simple observation.
But something like, Reuben, we're struggling at Jackson Hines trying to find space. And we have all of this sitting here. Wouldn't it be nice if we could find a way to use some of this space? That's where it started.
What more logical solution to an obvious problem? There was plenty of room for most any endeavor inside the nearly empty mall, as evidenced by the empty spaces in the parking lot just outside, as seen from this aerial photo taken in 1995. Compare that to today. And it's a good thing Dr. Shirley and Judge Anderson and Dr. Walter Conley of UMC, who also needed additional space for his facility, didn't comprehend the impossibility of doing what they had envisioned doing, taking an old retail mall on its deathbed and performing a medical miracle and bringing it back to life like it is today with retail shops.
Okay, so I won't show the whole film. The thing is, Aaron Shirley was a champion of civil rights in central Mississippi back when it was, back in the day when EDRA was born, in the mid-60s, when it was a highly charged political act to say that the black residents of Mississippi deserve to have access to healthcare services. The Dr. Shirley, since deceased now 5 years, joined a bunch of very, at the time, radical physicians who advocated on behalf of poor black folks in Mississippi, and they didn't have access to healthcare services. And they had to go to doctors who would actually provide those services to them, and they didn't, so health access was diminished, health outcomes were dramatically affected, dramatically different for those populations. When Dr. Shirley saw an opportunity to take an empty strip mall, well, not a strip mall, it was a mall that was built in the, you might recall the saving and loans disaster during the Reagan era where they overbuilt. He put, anchored by a tenant from Jackson State University Medical School of Public Health, was able to bring providers that were interested in serving this population into one place, and has created a very high quality, one-stop service mall that black populations travel for hours to come to because they know they're going to get the quality of service that they deserve. So he, as an advocate, fought for these things, and now he's been able to make it work by working with local folks in economic development to build something that's in the best interest of the medical, of the residents, particularly the underserved residents of the surrounding counties. And this to me is the best evidence of how collaboration works in planning and design to fulfill a very necessary social good. So I will now try and, if I can do this. Okay, and this is Dr. Jack Geiger. If you could just bear with me for a second.
And this administration today, here and now, declares unconditional war on poverty in America.
I think it was necessary because we had had so much visible social upheaval, riots, assassinations. In fact, we already were two nations, separate and unequal, along the chasm of race and ethnicity. When the war on poverty, Medicare and Medicaid started, we had a national poverty level of 22%. 10 years later, it was 11%. That's without precedent. It has crept up back with the abandonment of those kinds of interventions and policies into something better than 14%. What is not reflected in that number is something community health centers, particularly in urban areas, know very well, which is that we have created great urban concentrations of poverty, which have developed pathologies all of their own. And we're going to have to find ways to unpack those concentrations of poverty. And the Supreme Court ruling to strengthen fair housing laws and their implementation will help. We have had a decade of research, attention, and discussion to the social determinants of health. We know that to be born poor is to live a shorter, sicker life. We know that a childhood in poverty literally is embodied in changes in the brain and brain structure that clearly have something to do with subsequent illness, poverty, and a shorter life. And so we are really starting again to pay attention to intervene upstream in the root causes of what are making people sick. And I expect community health centers to have a new life in that kind of social and environmental intervention as part of their work that characterized the community health centers at the beginning.
Okay. So trying. So, where does that leave us? As an advocate, I understand that we're not nearly done with the work that's going to be required to fulfill what these gentlemen are. They are heroic for having been able to do what they've done, but there's just so much more that remains to be done on the advocacy front. And for me, I've had success being able to forge collaborations with various in different areas of concern, but who understand that really the investment we make in providing the support and access that kids need, and particularly poor kids, because they're our kids. Whether this country, this great experiment that we have in democracy, and wanting to try and lift everyone up, requires us to be creative and collaborative. I know that EDRA has 50 years of exploring these issues and a wealth of understanding and knowledge about what it would take. And it doesn't, no one group or organization can do everything. But I just wanted to extend an invitation. We do advocacy on a broad range of things. I talk to folks all the time who are talking about environmental stuff and planning communities and making sure the voices of stakeholders are heard and respected and included. That's the duty roster going forward in terms of advocacy, and that's, to me, what recognizing that and just speaking out about it and challenging folks to get on board with it and to think of ways to do it themselves internally and to partner with others externally. That's to me the how advocacy leads to stewardship. So, at some point maybe I can, I don't think I will, but can ramp it down a little bit and enjoy my grandchildren and pass the mantle on to other folks. And I'll just leave you with a couple of quotes. One from one of my favorite people in history, Winston Churchill. There is no finer investment for any community than putting milk in babies. I was really surprised to see this because, he's someone who's generally associated with things other than social programs, but even he could recognize that the quality of this investment. And finally, now I'm going in the wrong direction. And finally, Frederick Douglass was quoted as saying, "It is easier to build strong children than to repair broken men." And this is very much a bottom line philosophy for me. I sit on a number of boards, including First Focus for Children and other organizations, and we're focused on those nuts and bolts issues around resources and funding, and it's there could be no better investment than a more important investment than in children. And really, they're not that expensive, but the payout is incredible. So, thanks for letting me talk about this. I'd love to, if there are any questions or comments. Okay. Thank you. Oh, okay. Yes.
Thank you very much for what but I want to know how to remain so positive and aspirational in the face of knowing that we do know how to take care of children and that we refuse to do it.
Right. It's a great question. And, when I first got into this line of work, it seemed like a no-brainer. I said, oh, this isn't going to be difficult. I mean, of course, everybody supports the needs of kids, but there's a lot of need out there, right? And we have a very deliberative legislative process, and it involves consensus building and lobbying, so when everyone professes to be concerned about kids. I go to offices. I work with Republican offices all the time, and it's really not difficult for me to find people who are very sympathetic and are willing to do certain things, but they can't go all in because right behind me is someone from AARP or someone from the American Cancer Society or someone from and all these folks have very compelling stories to tell as well, and they vote and they donate, and kids do neither. So, I mean, people they're typically if there's a situation like the one my boss is writing, my former boss is writing about the border situation. When children die, people are concerned. When children are put in cages, when children are abused, it tugs at the heartstrings and it offends the moral fiber of the population. But as soon as that passes, and it passes quickly, it's back to business as usual. And when the big decisions get made, we're lucky if we're in the room, because if someone's putting $10 million in donations on the table, or someone is representing a constituency that can deliver millions of votes, it's the needs of kids, as urgent as they might be, are secondary. That's just a fact. So.
I think the most classic example of that is that Imodium is a penny worth of prescriptive medication, and how many children died from diarrhea because of policy and the pharmaceutical industry. And we talked about the ability to get, we knew what it was that could solve chronic diarrhea. We had access to it cost nothing, but the politics.
Right.
And maybe we also look into public finance.
Yeah, no, that's not a bad idea, but that's still, I'd like to think that would be the silver bullet, but look, I mean, we're a wealthy country. There's a lot of influence that is brought to bear on what the priorities should be nationally, what the agenda should look like, and we just have to continue to make the case, an evidence-based case, that investment in children is worthwhile. I, for one, would like the Medicare and Social Security programs to remain solvent now that I'm 65. Okay, and in order for that to happen, we need a thriving, robust economy. That economy requires skilled workers, well-educated workers, and sufficient numbers of them. And essentially, that's how a lot of these decisions are going to end up being made. You hear a lot of sturm and drang about immigration and all that stuff, but we actually need immigrants in this country in order for us to continue, this thing. So I mean, yes, the political process isn't perfect by a long stretch, but so it's incumbent upon us to leverage it in every way that we can on behalf of kids, and it takes some creative thinking, okay. Yes. Was there a question out there?
Hi, bring to advocacy, like upfront and in our face and extra. And like poverty, it seems that one of the other elephants in the room that actually can help prevent, right, illness and loss of human potential is the area of environmental health.
Right.
And research is great. Research time and actually obviously roll back a lot of public support for environmental research on our waters and on our contaminants. There's still air. But
Right.
even on our everyday could get handled if people knew more about the impacts of our exposure.
Right.
And so I guess the question I'm asking is that being embraced at all in any of the, I mean, I know there's a lot of fires put out.
Right.
And this is sort of an upstream kind of, approach, but is there anything that you know of that any of the, the programs that your children health or the mobile clinics are doing to sort of help bring that in?
Well, we could always do more, just as a generally speaking, and as part of, so when we're dealing with, because it's typically primary care that we're providing, and the nexus between primary care and the environmental factors you're talking about is significant. Things like asthma and, kids living in contaminated circumstances, and we bring it to the fore that way. But there are some organizations, particularly on the side, that are looking deeper into, we were very involved when the water crisis, became known in Flint. We, sent the mobile unit out, and we worked very closely with Senator from Debbie Stabenow, who's a champion for kids, and in Michigan to try and bring public attention. Mona Atisha, who's been the public face of that, who uncovered the malfeasance, is I'm proud to say, as a friend, her husband was the medical director of our Detroit Children's Health Mobile Program. So they were involved, but it's not enough. And we really do have to, now that, and there are there are powerful interests that act as a counter force because there's been, particularly with this administration, the sense that we need to deregulate rather than regulate, and that, oftentimes in circumstances like that, we find the children's advocacy community finds itself playing defense and just to maintain the line that we have and not roll back things. So I think with this new generation, and I put most of you in the new generation, myself and the older generation. There's a much higher degree of awareness of environmental issues. You see it starting to express itself commercially within our economy, and I think that will start to invigorate, more focus on dealing with those things in a more direct and aggressive way, because younger folks, younger families, they just won't put up with it. They won't, they're intolerant of that kind of nonsense, and it reminds, every time I would look at the Mad Men, and I would see an episode where the OBGYN guy is smoking in the examination room, and you think, really, did that happen? But it did, and it's far-fetched now, and I think a lot of the stuff that we put up with now and tolerate is going to seem far-fetched pretty soon, frankly.
In your slide, one of them, you talked about transportation.
Right.
Accessibility.
Right.
One of the things that you haven't mentioned is the whole role of recreation.
Right.
And parks.
Right.
And, physical activity.
Right.
And, of course, it's a big interest of many of us.
Mm-hmm.
And, the whole notion of youth programs, recreational programs, which are health preventative.
Right.
Are you involved in any way in that, or are your lobbying efforts often done and with other organizations such as NRPA or other recreational types?
That's a great point, and we haven't really been cognizant enough of the potential to partner with organizations like that. On the transportation side, our concern was that we had kids who needed access to healthcare services, couldn't get there, and they were being impacted in a negative way because of that. And I actually, was deeply involved in transportation as a health access barrier. I'm considered by some folks, I still don't know why, as being somewhat of an expert on it. We developed this index, and but when I reached out to the American Public Health Association and their just the gorilla in the room on public health issues, and we said, look, can you guys take up transportation? Their version of taking up transportation was more oriented to what you're saying. They said, we want to build livable communities where residents have access to bike paths and can, they took that take on it. I used to get frustrated because I didn't understand why they weren't seeing it from my perspective. And now I've learned that, it is more of what's required here is a more integrated approach. And that's one of the things that we're looking into. In terms of social determinants, that ranks as high as any other. We have communities that support recreation and exercise and health and activity, because it's one of the best bulwarks we have against things like heart disease and hypertension and all that stuff. It's just certainly as important as having a healthy diet. So yeah, that we need to do more of that and increase our bandwidth to have those conversations. Yes. American what? I'm sorry? Restroom, okay. Yeah. Mm-hmm. Right. Right. Right.
So I'm wondering if you have anything to do with that, or you're interested in looking at perhaps that group, because it would be a very small organization, but we have a lot of media coverage and we've been very effective in helping change building codes.
Right. Well, that's a great issue. I mean, I never, this is the first I'm really hearing of it, and I'll be honest, I think it's anyone who's had who's experienced not being able to use a restroom when they've needed one, or on the humorous side, having to watch the very phenomena you talked about. You go to a public event, and the line going into the ladies' restroom is enormous, and the men's restroom. I've actually witnessed guerrilla activity where women have commandeered the men's room because of that, and I would think that anyone who was enlightened about it would take that into consideration, that very real set of circumstances when they design and build large public facilities or any facility. So we haven't done it, but certainly I'd love to find out more and see if there's look, we've managed to put changing tables in restrooms, and and recognizing, we've managed to recognize that there is not just it's not something that we can kind of just put to the side and not want to think about. It bears thinking, being very thoughtful about it to accommodate what's necessary. Yes, without a doubt. Yeah. Yes, agreed.
Sir?
Yes. Oh, great. That's right. I neglect. After Hurricane Maria, as you know, the island was devastated. I don't think they, really felt they were getting the kind of attention they needed when Donald Trump was throwing paper towels at folks as they waited for emergency supplies to arrive. But they've had there are issues with Puerto Rico. They've had chronic problems in terms of governance and management of resources and need on the island for quite a while, and the hurricane just brought it out into bold relief. Our part, because we've gone in response to those types of circumstances in the past. In 2005, we were able, because we had been doing advocacy and had great relationships with some of the congressional members in Louisiana and in Mississippi, we were able to bring mobile units in 2 days after Katrina left, and we were providing health care and ended up setting up programs with Tulane and Our Lady of the Lake in Baton Rouge that exist to this day. And so we have some, this is a partnership between the National Center for Disaster Preparedness at Columbia's Earth Institute and the Children's Health Fund. We put together a joint effort called Operation Assist. We worked together in going to Puerto Rico because we knew that there were some excellent on-the-ground federally qualified health centers on the island. And so we bypassed the official structure and forged a partnership. And Mark Anthony, the entertainer, was kind enough to help us raise money, and we launched a mobile program there that's been underway now for some time. It was such a good partnership that we've been invited now to replicate our Healthy and Ready to Learn initiative, which is the one where we go to schools where there are kids who are missing school because of very preventable health conditions, and we help those schools to screen and address those conditions and to deal with things like trauma. Trauma-sensitive schools is now a big, you'll be hearing a lot more about that. ACEs, adverse childhood experiences, toxic stress. Dr. Geiger mentioned briefly about brain development and plasticity. There's a lot of interest and evidence now that demonstrates that a number of the problems that we thought were intractable, unsolvable, have roots in things like adverse childhood experiences. Kids who have dealt with trauma continue to deal with trauma, and that we need to really be thinking about how to get those kids reoriented, providing a lot of behavioral health services, and to get them back on track and hopefully successful, instead of just consigning them to their own track of failure, and and to a certain degree, becomes evidenced in the prison, school to prison pipeline that they talk about. There are ways, new ways of thinking to engage, and Puerto Rico is giving us an opportunity in a fixed environment, one that I'm pretty excited about because we'll be able to measure what we've done in that system. We're going to have access to a series of schools there. It hasn't been signed off on yet, so I can't I can't say that with 100% certainty that we'll do everything that we'd like to do, but we're pretty excited about the prospects. Did I answer that, or do you? Yeah. So everything, recognizing the importance of that relationship. I mean, maternal and child health, they're inextricably linked. And so when we're doing our school stuff, there's always a very robust presence of family engagement measures. It's part built into the model. And I should have brought this with me. We were able to get funding from the New York City Council to stand up a Healthy and Ready to Learn Training and Resource Center. And we've gotten all the content relative to health barriers to learning and parent engagement and all of the things. We have a course that the Teachers Union is certified. They can take for credit, and it's all free and it's all online, and it's all supported with public dollars, and it's in English and Spanish. And so if you go to Children's Health Fund under the tab childrenshealthfund.org, under the tab Healthy and Ready to Learn, you'll find a link to it, and it's worth checking. One of the most exciting things we're doing in our New York program, which is by far our largest project in our network of projects, is a thing called the Mother-Child Dyad. It's a new way of dealing with providing pediatric services to mothers and their newborn children, starting in the prenatal stage and following through for the next 1 to 2 years after they give birth, where they have groups of parents meeting with instead of one-on-one pediatric professionals. At the same time you're informing them and they're getting FaceTime to talk to providers, they're also bonding with mothers in a similar setting and forming those important networks that communities provide that were essential at one point, it seemed, in every community. You'd have a network of moms and parents who would be the fabric of that community. And it lifted up all children, because all children were accountable to it to a certain degree.
So in closing, and thank you, I also want to say that I looked to the Children's Health Fund because we were running this conference, I'm one of the conference co-organizers, about sustainable urban environments. And the Children's Health Fund has an entire sector of it that is a response arm of the organization that goes immediately to areas where disasters have hit, where the vulnerability of children, because of our interest in design and rebuilding, so often what gets rebuilt is all temporary and will never be temporary, it becomes the lay of the land, and that has a horrific impact on the ability for children to have childhoods where they can thrive. And in looking at the arm of the organization that did that, I knew that that was not Dennis's arm, that he was policy and advocacy, but I thought it was equally important at EDRA for us to be having the conversation of stewardship in this way. So you've given us some of both, which is terrific. You've done your part to give them so that that partnership can be symbiotic. And I'm thanking you.
Oh, I appreciate it. I really, you know, as a lobbyist, I never get tired of talking. And if so, I urge you, if you go to the children'shealthfund.org website, you'll find stuff. If you go to the ncdp.org for the National Center for Disaster Preparedness, you'll find information there. And on the advocacy side, if you go to First Focus and look up the work that they're doing nationally around children's advocacy, I happen to be a board member. They can put you onto a number of the different things that I talked about relative to the legislative and policymaking process. Right, that's right. I hope it was good.
Professor of environmental psychology, so I wanted to introduce myself. But
wow.
It is celebrating the 50th anniversary along with EDRA at CUNY. It's a CUNY Graduate Center.
Okay.
So it brings all these disciplines together.
Okay, I'm going to give you a card, and you know, maybe there's something for us to talk about.
EDRA doesn't have, as you can see, EDRA is like white.
Yes, they are.
So it's important at least to start to bring up
Right. Equity issues. Yeah, I agree.
Yeah,
I agree
yeah.
because there are a lot of black and brown folks who are interested in these issues. I have to tell you, they are. I mean, and I just don't think. I mean, look.
I've been working with New Jersey Sierra Club, and they started an EJ subcommittee, and I'm like, except they're 1% white,
Right.
1% people of color, so they're having trouble getting an EJ committee. I'm like, maybe you shouldn't use that word. This folks on top.
Right.
So,
Yeah. So. Sure.
more effective if we work together.
That is
Nice
true,
belief
and that
system.
not only are we more effective, it's the only chance we've got. I mean, we don't work together. We're gonna hang separately. Is I'm mixing metaphors, but if you don't hang together, you hang separately. When nothing
But you
drives.
need the tension on the ends. I respect that.
Right, no,
you need that pulling.
Right. No, I don't have any problem, and I have no problem. I go anywhere and talk to anyone. I've talked to more people that folks say you can't talk to them. I said, what do you mean I can't talk to them? I'm gonna go talk to them. You know what I mean? And I'm gonna try my best because maybe I don't get what I want, but maybe they hear. It's like dealing with teenagers. Like to my wife, you talk to your kids with teenagers, and they're resistant. They give you a lot of pushback. But you know what I found over the years? They hear parts of it. They hear it. They process it differently, and you just have to keep going back at it, and maybe somewhere along the way you learn stuff too that you might. Nobody's too old to learn new stuff. I've learned that too. You know what I mean? So.
Yeah, that's a great
Anyway.
organization.
Well, thank you.
I sort of heard of it, but wasn't
Yeah.
that familiar with it.
Sure.
So thank you
Sure.
so much.
Oh, my pleasure.
So glad that you came.
Great school.
Thank you very much.
Yeah,
I've been
yeah.
there 35 years.
Really?
Wishing
Okay.
A long time. So
Wait a
very
minute.
nice to meet you, Dennis. Thank
Pleasure.
you for an excellent presentation.
Well, I hope you enjoyed it. Thank you.
I learned a lot from
Okay.
you.
Okay.
So
Well, if you ever think of Illinois, how far are you from Milwaukee?
kind of far, 4
Okay.
hours.
Okay. Because we had some folks come in from Marquette who are thinking of who want us to help them put together a mobile project, and because they've got some the leadership of the institution is a pretty visionary guy, and he's done some interesting stuff, and so
I guess I was thinking in connection with my ARA group and
Okay.
getting the restroom issue incorporated into
Right.
this in some way, shape, or form.